Hi, I'm Craig Allen.
I'm Jeff Gursky.
Hey, over this last year, we fielded a lot of calls, and we've enjoyed the time speaking with both police and fire about just some of the nuances or the intricate components of R2TM. So with that, we thought we would spend some time and just answer more specifically some of your predominant questions.
So we are going to visit the top 10 questions that we get as far as active shooter response and how it applies to public safety.
No, law enforcement does not do formal triage when we encounter patients during our sweeps. The focus of law enforcement, again, is to do a quick assessment. And quite frankly, look, here's the deal. If they have a bullet hole in them, they need to go to the casualty collection point. We're not going to expect law enforcement to get into understanding the different nuances of triaging and advanced medical care. Our job is to mitigate the threat, lock those quarters down, and get those patients to a CCP.
When it comes to hemorrhagic care versus advanced medical training for our law enforcement counterparts, the question we have to ask is, how does this affect our resource allocation? Now, if we have all of our resources, or a lot of them, are law enforcement conducting these advanced medical procedures, what are the other things that we need happening? And then what do we do with all of our EMS resources coming from behind? And that's where we've always said that we think that people should stick to their own swim lanes and be experts of the fields that they're in. Most importantly, we need to understand our basic strategy first, then we can customize our response around it. What I mean by that is it has very little impact of training law enforcement on advanced medical procedures if we do not have an effective way to have law enforcement get those patients over to fire and EMS in a timely and effective manner.
The casualty collection point is not like the solve-all of how police and fire integrate. It's simply a component of the integration process. And what I mean by that is the casualty collection point really is the hub of operations, where police and fire meet, where we carry out our business. Without question, you can have multiple casualty collection points. You can have potentially one on the interior, one on the exterior if you need to. But really at its heart, the casualty collection point gives us an area where we can direct resources out of, where we have those officers on the interior. They have a focal point where to bring patients, and it just gives us some focus and clarity in this first 15, 20 minutes of a very chaotic event.
As Craig was saying, you can have multiple CCPs, but we do urge that you should only do it out of need. Creating multiple different layers and multiple different operations in your incident will take time and resources, which will take away from those resources available to mitigate your problem. The CCP should be placed strategically, meaning, where on your structure and your geographic areas, where's the greatest place for entrance and egress and security for your fire and EMS personnel, as well as the victims.
Okay, you may be asking yourselves, that sounds great on paper, sounds great in this video format, but where do I put that casualty collection point? Let's not make this any harder than it needs to be. Quite frankly, if you look at any structure, even large structures, there's only so many areas that are kind of strategically located, that have good ingress, egress, that are large enough to work within, with the ability to secure, and so forth. We talked about in our previous presentation, foyers, gymnasiums, main entryways, all of those are rather intuitive to set up casualty collection points. We don't expect law enforcement to somehow run around the structure and do some mathematical equation where to put it. Be decisive, grab that territory, call it a casualty collection point, and start pulling patients there, as so long as it's in a position where we can get fire EMS in. But let's talk about this further. This is kind of a two-sided coin. We don't expect you to go out and pre-plan every location in your jurisdiction where to put casualty collection points. But again, let's go back and look at some of the data. Roughly 1/3 of these take place in schools, and out of those schools, predominantly high schools. So now we can look at that population group and probably identify at least primary, secondary, tertiary casualty collection points. Businesses or commercial areas make up the other third. So now we're at 2/3 of what encompass all the active shooters. So there, if you have a large business in your jurisdiction, might not be a bad idea just to kind of say, hey, what's a likely primary, secondary casualty collection point? So who's in charge of the casualty collection point? Again, for law enforcement, you pick that location. Be decisive about grabbing it and locking it down. But ultimately, fire, you control that area. That's your workspace. That's your area to conduct an MCI. It's really that marriage between law enforcement and fire in that location that we believe creates an effective way to get patients in and get them out of there.
As we define this within an ICS structure, on the fire and EMS side, that officer, whoever's in charge for the fire resources in there, most likely going to be the medical branch director, can kind of assume the fire EMS responsibilities of everything occurring on the CCP. For law enforcement, a sergeant or a hall boss, whoever else is kind of in charge of the security in that, those two individuals to work together. So it's kind of a unified command within the structure. A forward operating base and a casualty collection point are two very different things. They both have two different functions. It's important to remember, especially as a forward operating base, although it has its great purpose, if that purpose and the activities going on within that do not allow for the operations of a casualty collection point, the two should never be occupying the same space. However, it is possible for that forward operating base, as the incident operations move forward, that we can follow behind, turn that into a casualty collection point, and have both operations on the interior.
But let's take this one step further. How does this look for those officers responding on the call of their career? Again, the FOB is run preferably by a sergeant. It could be an officer, but typically those officers are going to most likely one, if not a couple of very intuitive entry points on the structure. I doubt that you're going to have officers, circle the structure and come in some arcane back way. So the point of the FOB is if we can grab that territory, start interior operations, potentially that FOB could grow or it could turn into a casualty collection point because it's already based off of good ingress egress. That's what we mean by the FOB could turn into the CCP, but they are really still two different entities. So think of it this way. The casualty collection point is just a quick connect for law enforcement and fire to get together and start commencing dual operations.
Now this quick connect or umbilical allows the full capabilities of EMS to enter the scene as needed. To logically defend this approach, it embodies many of the principles of the 9 principles of warfare, specifically that of mass, offensive time, simplicity, and economy of force.
And quite frankly, without a casualty collection point, what are we left with? We're left with officers exercising great initiative, but where do we bring the patients to? We've seen this in NIU, Virginia Tech, numerous incidents. Law enforcement is then left to get the patients out to fire stage or throw them in the back of a police car in blind transport. Neither of those are good options. A casualty collection point is able to bring stability for that moment of time in a very chaotic event.
Within any active shooter or any kind of response that requires multiple jurisdictions and various response entities, we need to follow the standard ICS model, which is NIMS. Now, I think oftentimes we overcomplicate what our ICS structures should look like. Now, as we've said before, an active shooter event is typically a type 3, maybe type 4 incident. There is no conflict with our model and how we integrate with ICS. Matter of fact, if we simplify ICS into its root foundation of what it stands for, it is task management. If I was building a piece of furniture here and I had complicated instructions and I needed help, it's just simply asking people to come in and help me so that we can accomplish a task together.
One thing inherent with our 2TM is we keep police and fire in their respective swim lanes, so when we let them work on their own individual areas of expertise. Once we start getting that two intermingled, you start sending teams of law enforcement and fire down areas that we believe have been swept, maybe, maybe not. We have a problem there because Unified Command now is going to have to buy off on where that rescue team goes. For instance, if we're looking at the tactics we're using under ICS, there could be a time where Unified Command, police and fire disagree on where that element's going to go. Here again with our 2TM, police do their job, fire does their job, limiting the amount of disparity or disagreement Unified Command could have. And again, we've talked about it, Moose Must, those 9 principles of warfare. Take the U, unified or unity of command. Napoleon said it best 200 years ago. There's nothing more important than an undivided command. We know this. So the question is, why aren't we doing a better job getting police and fire together? It's important, guys, that we learn as we move forward with whatever model you want to choose. That is going to be the first foundational piece that has to come to fruition.
R2TM encourages a unified command. And we do this by simplifying the expectations and decreasing the complexity that unified command may be posed with. To start off, this model doesn't require any additional equipment, which means it doesn't require any additional equipment costs. It does require a little bit of training, but the training is minimal because it's built upon a foundational response that's simple and something we do every day. It's important to note that with R2TM, we are maintaining occupational swim lanes. Fire EMS stays in their swim lane, law enforcement stays in theirs. It requires very little to no cross-training, but most importantly, it makes it so we don't have to learn each other's jobs.
Another aspect of training is to look at what type of training we're going to do. Make no mistake about it. Embarking on getting your police, fire, EMS together is going to be a daunting training task because mainly we got to get everybody through that training. Now to compound that, we want to look at, are we doing more skill acquisition training, aka learning a new specific tactic or technique? That's going to take time, as opposed to what we believe in R2TM is more of just kind of a familiarization of new concepts. And that utilizing those officers and firefighters and skills they already do every day. Just to kind of recap here, because the casualty collection point is secured by law enforcement, we don't feel there's a need for firefighters, to need ballistics gear. We tried that back in 2006 and 2007 and we weren't successful with it. Let's go to some of the law enforcement gear. Guys, I'm with you on this. I like gear and I like doodads. Our patrol cars have some kits in them in terms of additional mega movers and tourniquets and magazines. But let's be clear, the focus on this should not be on gear and equipment, although that can help. The focus here needs to be on how do we integrate. Once we get that figured out, then adding some different tools and so forth can complement that, but that should not be the focus. But let's kind of just close with this. We want to keep the firefighters safe. If a fire department feels the need to have ballistic vests, great. I'm all for PPE. But I just would kind of want to add to that, 70% of all active shooters going back to 1966 do what? What kind of weapons do they have? Rifles. Ballistics vests don't do a lot against rifles. Yes, you can mitigate that with ceramic plates, but I think we might be going a little bit too far down the rabbit hole to expect firefighters to don ballistics gear with ceramic plates to come into a situation and start doing advanced medical treatment, or at least medical treatment on patients.
We should give law enforcement the amount of medical training they need to accomplish and to help perform their job and their normal duties every day safely. To get into, should we be training law enforcement on advanced airway techniques and other things within the advanced medical care, the question that we should really be asking ourselves are, what's the sustainability of the practice versus frequency of use? Because if we're not using those skills frequently, they will diminish, and then hence, our medical practices are no longer sustainable. If we do choose to provide our law enforcement brothers and sisters with advanced medical training to provide direct threat or hot zone medical care, we have to question ourselves, how much more time is that patient or that victim going to be spending in the hot zone versus how quickly they will get off to definitive care? Referring back to the other videos we've made, looking at scene times and penetrating trauma, we are going to be increasing the mortality rate by keeping those patients on scene. We do need to recognize the recommendations of organizations such as PHTLS or TECC and what they say should be done as far as penetrating trauma or blunt trauma in field. It is important that we use sound practical judgment of how far our agencies can take those and the level of care that we're providing our patients. For instance, dealing with a tension pneumothorax, is it appropriate to provide LE the training and skills to do that versus EMS providers who are doing that on a near daily basis?
But let's recap this here in terms of how much more medical care does law enforcement need. Tourniquets are it. Give law enforcement that training they need for tourniquet use. We've already seen through the studies and through just numerous incidents even across the nation, tourniquets help. And the other thing I would probably add is for law enforcement, get those tourniquets out. Start using them at live fire training. And just become familiar with that. That's a great tool that we can use both in direct and indirect threat care.
Most importantly, when it comes to medical care, we need to remember that we need to be treating the problem and not the symptom. If one of our problems is how we integrate EMS, Treating the symptom by having law enforcement do medical care is not taking care of the problem of how we're integrating, which means that we need to be treating that problem first. Quick fixes may not be real-world practical. Matter of fact, I think that we need to keep the TEMS in context for what it's expected to be. What TEMS was designed for was medical care for SWAT team members, not to attend to the needs of a mass casualty incident.
All right, this is a big question. How do we train? And probably one of the more important questions. Look, let's make it simple, right? We want to have some sort of a philosophical understanding, some sort of lecture, so everybody understands what objective, how are we going to do this integration. Once that's set, we want to go out and we want to drill it. We don't want to jump into scenarios. We don't want to jump into high action integration scenarios, because that's going to just lead to confusion. You want those crews, you want those officers to simply walk through the mechanics of setting up casualty collection points, having the officers work on fire security. What does that look like? Having those sergeants and the battalion chiefs just do a quick link up. Then that sets the stage for moving on to kind of test that in a scenario. For those of you that are like to read and do your own research, the Tactical Decision Making Under Stress is probably the hallmark book on how to appropriately layer and build your training. That came out of a 10-year study after we unfortunately shot down an Iranian airliner, and we learned some lessons about how to appropriately layer, drill, and conduct scenarios both for individual and team tactics. And here's just one last piece I want to touch on. I think it's very, very important that both police and fire, all members, have a general understanding of what attack strategy we want to do. What integration model, how does this look? Once we have that figured out, then commence the drilling on it, then commence the scenarios. If we get those out of order, it's going to create just more confusion for the crews and for the officers.
So how does this happen? First, we need to get all the players in the same room. And when we have all the players, we're going to do a lecture, an active shooter, an EMS, as well as law enforcement response overview, which would take about 2 hours. After we do that, we're going to separate people out into their own functional groups so they can learn triaging, tourniquet use, drags and carries, law enforcement tactics, security. After we've done that, we're going to set up a small drill and we're going to work on transition training, having people understand when do we transition from threat mitigation back to victim mitigation. By the time you get to your first scenario, it should only cost you 6 hours per service member to be familiar with the rapid response and treatment model.
We recognize small agencies have small resources, and in that case, they need to be creative with how they apply those resources. And then to adopt models that are overly complex in terms of the time it takes to train and to integrate can be problematic. Even with the large resources of big agencies, there's still problems. If we're looking at trying to adopt a model that has a lot of skill acquisition training, how do you go out and train thousands of personnel on a particular type of a tactic which might be very specific in its application? Again, that's why we would recommend that that model needs to be simple in design, therefore it applies both to large and small agencies. But you know, even with our 2TM, there are 6 other additional components that might be new. Corridor lockdown, fire security, casualty collection point security, and so forth. Again, for large agencies, this is a great opportunity to kind of disperse those different job activities across your pool. It gives something for those members to do. Because what we've seen is, in these large agencies, you could get 400 personnel responding in 15 minutes and absolutely inundating or overwhelming the command. And small agencies will have the same task to accomplish. However, they're just going to need to be creative with how they do that. You know, in some sense, it may be kind of triaging those priorities of what need to get done.
And let's not forget about our neighbors. If we're small agencies and requiring on the support for our surrounding communities, we all have to be collaborative of what choice we make. And the same is for big resources. If this is going to happen on the edge of our jurisdiction, it's going to require mutual aid response. Everybody needs to be able to plug in. So in a sense, large agencies and small agencies both have the same problem. The solution is to find a model that minimizes the time, resources, and equipment needed to conduct it. The answer is no. Regardless of what we're hearing, to say one model fits all needs is ludicrous. Ultimately, what we need is agencies need to have a model that's customizable based on your agency culture, your capabilities, your sustainability, and your current practices.
You know, both Jeff and I recognize there's a lot of good work being done out there across the station on how to integrate police and fire, and we certainly respect that. It's long overdue. Really what we're emphatic about is for those agencies to understand why we're doing it, and not just simply adopting a model because you heard it here, you read it in a magazine, your neighboring jurisdiction might be doing it. You want to make that integration model work for you guys, for your agencies. Again, lastly, if you're a resource poor agency, that could be big or small agency, don't commit to something that could be intensive in terms of time, training, and money. Make it work for your agencies.
By having law enforcement transport victims to a hospital often implies that it's going to be blind, and we should always avoid blind transport because we're simply going to probably shift the MCI from our scene to another. The hospitals that are receiving these patients might not be set up, for example, a community hospital, to deal with a gunshot wound. Vice versa, a trauma hospital might already been inundated with patients from your incidents or other incidences and may not be able to receive any. So now these patients are going to have to be re-triaged at the hospital to determine priority for surgical care. Now we have seen in some publications that transport by law enforcement may be or may have been beneficial. We've also seen this in post-action reviews from active shooter events. However, we both, and even these agencies suggest that this should be a last contingency. Even though this may have worked in a couple instances, we don't want to confuse good luck with good tactics. If EMS cannot commit into the scene, it may be a better option for law enforcement to transfer the patients to fire stage rather than to do a blind transport to a hospital. Directly referring to penetrating trauma and blind transport, that situation has cost lives in the past. And the reason being is that the hospitals might not be equipped to handle that, either on capability or patient bed availability.
This gets aid to more victims sooner. But look, without question, for officers to get into that scene quickly, mitigate that threat, neutralize the shooter, that saves lives. But we cannot forget the back end of that timeline. For those folks that are laying there bleeding, we need to continue that timeline and get those folks to definitive medical care. And certainly we believe the most efficient way to achieve this is to have those law enforcement folks that are already in there. That's an intuitive practice. Bring these people that have been wounded and get them to a casualty collection point.
Speaking from an EMS standpoint, after the progressive killing has stopped, there is still progressive dying. Now, no matter how efficient we can be as EMS, law enforcement is already going to be in this structure, securing an area for us. And so we can use those resources in that structure to grab those victims and pull them to a CCP before we even get in there, which is going to maximize life saving. Speaking to the physics of the incident, it's going to be much quicker for law enforcement who are already right next to the wounded to bring them to a CCP versus EMS going through the structure if Unified Command has already communicated that that corridor has been cleared or swept to get to that victim.
Without question, law enforcement, your first priority is threat mitigation. But just recognize this, once those immediate threat indicators subside, just kind of continual resweeping and resweeping does not aid in those folks wounded. We need to use our resource, get that casualty collection point up, and start pulling those patients there. This is very achievable and can have huge benefits in the overall life-saving process. And let's also remember, there's a lot more law enforcement in there than we have paramedics on scene that can attend to this task.
Let's highlight the most important thing when it comes to an active shooter event. Time becomes your enemy.
That's right, Jeff. Now, at the core of this program is police and fire working together to have a succinct impact on the mortality time curve, getting that patient to definitive medical care.